just did. I mean, there's a lot of that. It's very, it's like working with is different. I would say it's kind of like working with a site.
Good evening. Hello. Welcome. We've got a small group today, but it's going to be, it sounds like it's going to be a talkative group, so that's great. My name is Joe Spear. I'm the managing editor of the Mankato Free Press, and we welcome you to our Knowledge and Lecture Series, something we started last year, so this must be about the 7th or 8th one. And tonight, I want to make sure I mention our sponsor for this event. That's important. It's Minnesota Valley Federal Credit Union, and they happily serve those who live, work, or do business in Blue Earth, Nicollet, LeSueur, Waseca, Brown, or Watonwan counties since 1934. If you get anything out of this, give those folks a shout out. Tonight, our guest speaker is Thad Shunkwiler. He's going to talk about the future of rural healthcare delivery in rural Minnesota, no doubt an interesting and relevant topic for today. Thad is associate professor in the Department of Health Science at Minnesota State University, Mankato, and a licensed behavioral health clinician with over a decade of experience providing care in rural Minnesota communities. He founded the Center for Rural Behavioral Health, which aims to improve access to care for agriculture and rural populations throughout greater Minnesota. His accolades include being a fellow of the National Rural Health Association and the Emerging Rural Health Leader Award by the Minnesota Rural Health Association. As a peer-reviewed author, TED speaker, and keynote presenter at both national and international conferences, Professor Shunkwiler is a recognized leader in shaping the future of rural health systems. Let's give a warm welcome to Thad Shunkwiler.
Thank you, Joe. Thank you, everyone. Can you hear me? Would you like me to use the mic? I'm happy to do it. I have the lapel. Casey, do you want me to use the mic, or is this coming through the lapel okay?
You're okay.
Okay, excellent. Well, good evening. Thank you all for taking some time this evening to learn a little bit about my passion and the things that are near and dear to my heart, which is rural healthcare, and so thank you for that. And thank you to the Mankato Free Press for not only putting this series on and tapping into the expertises and the leadership that we have in our community to share it with one another, but also their work as a community newspaper. I think I'm guilty of taking that for granted in many instances, the work that the Free Press does in bringing the news of what's going on. And I just want to commend them for that doing that for our community. And so thank them, and also thank you for being here. We're going to talk about the future of the healthcare delivery system. It's a pretty heavy topic, as you can imagine, a pretty timely one given what's going on in the news, and one that is all but impossible to solve in a 30, 40-minute lecture, right? If I had the answers to these challenges that I could give you tonight, we'd probably be having this lecture in Switzerland, where I would then be receiving the Nobel Prize. Because as you already know, I mean, healthcare is so integral into who we are as human beings and our communities and our families, and yet it is at a crossroads to some degree, particularly for those who access care in non-metropolitan areas in more rural areas. And so kind of just jumping in, I don't have a ton of slides. I am a professor by trade, but I promise this is not going to be a death by PowerPoint, as they call it in the military, but rather just an opportunity to kind of show some what I think are important statistics, as well as an opportunity for the future. I guess I want to start by saying there is a lot of doom and gloom in the future of healthcare in this country, and particularly rural areas. And we're going to have a moment of doom and gloom, because we can't have an honest conversation without looking at the challenges that we're currently facing and coming ahead. But I don't want the conversation to end there. And we're going to spend the end of our time, before we open it up for some interaction and some questions, talking about what's going well, because I think we have a lot of really great things going on in the Mankato region that I think we need to leverage and we need to continue to lean into in order to solve these problems. So at the front end, it'll feel like the sky is falling, and that's a pretty typical college professor lecture. But I do promise that we're going to get to what do we need to do to move forward to solve these challenges. So if you think about healthcare in the respect of what's going on today and what's going on in the future. So today, literally every day, healthcare challenges are in the news. I mean, there was a great story just a couple of days ago by the Free Press team talking about the challenges with Medicaid, cutting Medicaid, and its impact on rural and community operations here in our community. And that is the current challenge. What's going on today is a lot of conversation of what's happening in Washington, D.C. and its trickle-down effect to St. Paul and ultimately into our backyards. And trust me on this, I just got back from Duluth this afternoon. And in Duluth, I spent the last 3 days at the Minnesota Rural Health Conference. And so it's like top of brain, these conversations. So it couldn't have been better timing than having me join you today, because I've spent the last multiple days talking with the leaders who are trying to tackle the current challenges of today. Our focus tonight is on, as the title would suggest, the future. And that's where I've kind of made my mark in rural healthcare research, is on not looking at what's going on today and looking at it, how can we solve it through policy and other interventions, but rather looking ahead, because so much of what we do, not just in healthcare, but just in our society, is to react to things as they happen in real time. I mean, that is politics in a nutshell, simply just reacting to the moment and what's happening or who's in charge. But I started out in academia saying, I don't want to focus on what's going on today. I want to focus on what's going to happen in the future, with the hope that at some point, maybe we don't react and we start to respond thoughtfully to challenges that we can see coming down the road. And when we're talking about healthcare, we have two big challenges, right? There are many. This is a very complex issue with lots of different facets, but there are two primary drivers to my work about what's happening in the future. And the first is right there at the top. I know some of you may not be able to see these, and you can all have access to this PowerPoint. I can put my email address up here and you can email me and I'd be happy to share this content with you. But the first challenge we're facing is we are getting sicker as a country. We often think of our health and measure it by life expectancy and say, well, we're living longer lives than maybe we ever have in the past. But that's not the entire story. Sure, we're living longer lives, but we're not living longer healthy lives. A better measurement of how we're doing is what we call a health span. How long are we staying healthy? Healthcare has done a great job of expanding life expectancy, but what it's ultimately done is just kept us alive, not kept us healthy. And that problem is getting worse. Every data point would suggest, just as a society, each year that goes by, we get a little bit sicker with chronic preventable illnesses. So that's challenge number one in the future, is that we're on a trajectory that is not so optimistic. On top of that, what we have and what we've been fighting now for some time is the healthcare workforce crisis. It's probably not news to you, but we simply don't have enough professionals, staff. We don't have the workforce to meet the growing demand for healthcare in our communities. And that is especially true in rural communities. That's the whole crux of why I started the Center for Rural Behavioral Health. I wrote a paper on looking at the future of the behavioral health workforce in Minnesota. And at the end of it, I said, well, is it enough to simply just point out the problem, or should we do something collaboratively to solve it? And so we became one of the first academic research centers in the country that was aiming to improve the behavioral health workforce to serve rural communities, and very proud of that work. And so for our time this evening, we're really focused on the future. We could definitely get bogged down in what's going on with Medicaid and all of the political back and forth, but we'll save that for another talk with a different expert, because there are people who can really speak to that piece a whole lot better than I can, but I like to focus on what's coming ahead. And on that kind of focus of the workforce shortage, what I don't think people understand is just how bad it is and how bad it projects to get. All of us have likely had something in our healthcare where we've had to wait a little bit longer, right? We want to get in to be seen, but now it's 2 weeks instead of the normal week. I just recently was at the VA, and for the very first time in all of my healthcare, I was told we don't have a lab technician to pull your blood, to be able to, check for what's going on. And so I, for the first time, just the last week, had the opportunity where I'm like, this is what's coming. This is what many people are dealing with, but it's on its way. Because what this pyramid here shows you is nationally. So we'll take it out of Minnesota here just for a moment. and just look at what's going on across the United States. And so the Health Resource Service Administration, or HRSA, is a part of the federal government, and their job is to kind of make sure that the United States has enough health resources to include health providers. And there is a wing of HRSA that looks at what kind of resources will we need into the future. And so they put out a report last year that said, these are the workforce needs that we have in this country by 2034. So it was a 10-year projection. We're now 1 year into that. And so me being kind of the research wonk and workforce kind of, guru, I started kind of doing some calculations, and I scheduled a meeting with one of the HRSA administrators to kind of test out okay, what do we actually need? What are the numbers that we need to meet the demand? And when I was talking with Tom, we were going through these numbers, and I said, okay, some of these are very doable per year. And he stopped me and he said, we just took what we needed over 10 years and divided them over each year. So whatever we don't meet this year carries over to the next year. And when he told me that, my heart sank, because I felt like there was an opportunity for us to maybe keep up, or at least get 50% there. But after he told me that, it became very clear there is no way we will ever produce the supply that we need to meet the demand of our healthcare, and that is a national statistic. And Minnesota isn't all that much better. We're a little better, obviously, just by pure numbers than what we need across the country, but we still have our own challenges as it comes to the nursing workforce and the direct care workforce. And the reason it's on a pyramid is essentially to kind of show you the level of education that one would need to be able to meet that demand. Obviously, with our physicians at the top, which is a career-long commitment, all the way down to what I often consider the most important people in healthcare, and that's our direct support professionals, those who work in the nursing homes and serve our community in various in various ways. And those are the ones we need the absolute most of. Now, oftentimes when we think about workforce and what we need, we have to have a conversation that also involves training, or in this case, because of these professions, education. And so many people say, okay, well, we'll just lean in on our university systems. After all, America has a great education system, and even Minnesota, right here in our community, a wonderful education system. And then we're hit with another bit of a truth bomb, which is we're projecting to have the lowest number of enrollments across higher ed ever. We are about to face you can see up here, at least if you can't read the numbers, what you see is a pretty drastic cliff of what we consider the enrollments. And so there have been recent stories, even in the Free Press this past academic year was writing stories, positive stories about MSU kind of exceeding its expectations in enrollment. And it kind of lulls you into this that, okay, things are going to be okay. But the cliff doesn't happen until this year. It is 2025, what it truly is just the number of kids graduating high school. It's about birth rate. And if you think back 18 years ago, it makes sense, because who remembers what was going on in the country 18 years ago, 2007, 2008? There was this big experience we were all having. Who remembers? It was the Great Recession. Yeah, housing crisis, recession. And that period of time, I guess, spoke to families and said, maybe we shouldn't have as many kids as we were planning. And so that started a kind of decline in birth rate, not only here in Minnesota, but across this country, and it's coming home to roost for higher ed. And what that means beyond just the impact on college campuses is those workforce. We need more workforce at a time in which we simply are not going to have enough bodies to train to be physicians, let alone serve in those direct support capacities. And so ultimately what that leads me to my kind of sky is falling moment is we will never be able to outsupply the demand. It is a simple math problem. It's not all that simple, but follow me here for a moment. It's a math equation that simply just doesn't ever add up. And when you think about it more locally here, it goes beyond just birth rate. As far as, where is the next generation of workforce, or where is the next nurse coming from? Here in Minnesota, we have a growing problem. And what I mean by that is there's a a concept called the dependency ratio. It's a demography kind of standard where we look at the amount of the population that is dependent on the other part of the population. And so it's essentially anybody who is not of working age. 18 to 64 is one group, and it's everybody else who isn't working. And obviously, you know, many people beyond 65 continue to work. So it's not a perfect statistic by all means, but it does give us an idea to measure like how many people are dependent on those who are working in healthcare, in education, in, I mean, literally everything around us. And so that dependency ratio is a really important statistic to understand the health. And then by health, I mean like economic health, the physical health of a community, of a region, of an area. And so if you look at where Minnesota currently is, we have a 55.9% ratio, and that puts us about middle of the pack in the country. And so what that means is that there are almost 56 people out of 100 in Minnesota that are dependent on those who are working. So there's more people dependent on the services provided by those working than are producing them. And so anytime it tips over 50%, it's not a good indicator. Now, as I mentioned here, 55.9 is about middle of the pack. Our neighbors to the west in South Dakota have the worst dependency ratio at about 73%. And so we're still doing considerably better than South Dakota, but that's changing with the migration patterns that we're seeing. And we'll talk about migration here in a moment. But when we project these numbers out in Minnesota, so if we go out 15 years, that increases 10%. So all this is saying, the trajectory we're on is that more people are going to need healthcare and consume it than we'll ever be able to provide it. And that has a cascading effect across communities when we have a dependency ratio above 55, definitely above 65%. And part of that reason, so we have another great resource right here in Mankato, but it's a statewide resource, the Center for Rural Policy and Development. Julie Tesh and that team are just fantastic in helping tell the story of rural Minnesota. And their most recent report was fantastic. So Kelly Ash and Marnie Werner just recently released a report about the population trends of Minnesota and looking at like where have we gone and where are we going. And so there's just two stats that I wanted to show you from Kelly's paper. I would encourage anyone in the audience or out there on Facebook to seek this report out. It's a very easy to read, and it kind of shows you where we're headed in Minnesota. You can see these lines here. This blue line is kind of what we call the natural change, and that is like a polite way of saying how many people are dying versus how many people are being born. And you can see here that we've been on a trend about the same time we mentioned in higher ed, where people stopped having as many babies, where we are now getting close to where more people are dying than being born, right? So we're still at a positive, but we are trending in that wrong direction. This green line is the net migration. So people coming into Minnesota versus leaving Minnesota. So they might have started their career here, but at some point they are leaving. And you can see that trend line is also going in the wrong direction. Now, we had some good news in 2024. That number went back up in the positive after having been in the negative for about 3 years. But is that a 1 year anomaly, or is that going to start being a different trend? And so all of this to say is it really highlights the future of rural healthcare is dependent on its workforce, and we're in real trouble when it comes to developing that workforce here in Minnesota. So then it leads to, well, what can we do, Thad? Like, we can't go back in time and start having more babies. Like, that isn't a possibility. And so how are we going to at least do our very best to meet what we have? And so there are a couple of strategies that healthcare is embracing. Well, embracing maybe is a bit of a strong word, but there are two concepts that have to be part of the conversation. And one is new Americans and the other is new technology. And so immigration, like healthcare, is a bit of a hot button topic today, right? Quite literally today, and has been for some time. But you can't find a healthcare executive or anybody who works in healthcare and does my work that wouldn't agree that the new Americans that we currently have and we need to bring will play a critical role in solving the healthcare workforce shortage, right? There's a fundamental truth in trying to solve these issues. And if you look at like our state and the healthcare workforce, the current healthcare workforce, and the percent that is made up of immigrants or new Americans, Minnesota sits in at just under 14% of our healthcare workforce. Can you imagine for a moment if we just didn't have those 14%? I got to do some policy work with some Minnesota senators last year around nursing homes in rural communities and starting to help tell the story of what is needed to keep these vital resources alive in rural communities. And one of the things that I learned in going around and touring and learning about the nursing home industry is how reliant that nursing homes are on immigrants to do that work. We often think of immigrants, and I'm guilty of this too, thinking about labor force, like working in agriculture or building buildings, and quite obviously they do lots of things, but I didn't understand just how instrumental they were in the delivery of healthcare, particularly in more rural areas. So if we're going to have a conversation about the future of healthcare, we have to include new Americans and the immigrant population as part of that. And the other one, which is scary and exciting at the same time, is artificial intelligence. And I don't have to tell you, if you paid any attention to the news, the speed in which AI is advancing and being utilized is remarkable, faster than any technology we've ever seen before. And so this conversation, even a year from now, might look a whole lot different. But healthcare organizations is in the delivery service system is embracing AI, which again is a scary thing. It's one thing to have AI or ChatGPT write your research paper for my class. It's another one to have them read your radiology x-rays and determine whether your bone is broken or not. But that's the direction we are going. Like it or not, that has to be part of the future, is that we're not going to have enough bodies, so where can we leverage and utilize this new technology? And I'm on a licensing board, and so we're having this conversation right now about, like, our job as a licensing board is to protect the public from, healthcare providers behaving ethically. Well, what if your healthcare provider is a computer? What kind of jurisdiction do I have as a license board member over a computer or software program? And so there's a real transformative philosophical conversation happening across healthcare right now, and where and how can we appropriately and safely use artificial intelligence. But don't for one second believe it. It's not going to be part of the future, because it already is. It's likely that some of your healthcare lab results or your screeners have already been analyzed by an artificial intelligence program and informing your physician or your provider about what might be going on. That is already occurring. So it gets me, so we need new Americans to be part of this solution. We need technology to be part of this solution. But it's a multifaceted issue that's going to have lots of different ways to solve. And so my big kick for the past couple of years now has been on, once I've realized there's never going to be enough workforce. In fact, I was up at that conference I was telling you about, and it was eating lunch with Terry Fritzma, who's the state's researcher on healthcare workforce. She works at the Department of Health. And I told Terry, I said, I don't ever want to see another conference proposal that talks about healthcare workforce and what we need to do to build it, because that conversation is actually keeping us behind. The minute we start to embrace that this math problem will never equate, we can actually have the conversation of what we're going to do about it. But instead, we keep kicking around pathways and these different programs, which are needed. I'm not saying throw them all out, but we have to start to embrace the idea of what we've just talked about for the past 10 minutes, that it's never going to work. So how do we, if we're in an economics class, and I'm not an economics professor, but just I'll play one here for a moment. If we have a demand that is up here and our supply will never catch up to the demand, the only way to balance this out is how? What do we have to do? If we can't increase the supply, we have to reduce the demand. And in healthcare, when we're talking about reducing the demand for it, we're talking about preventing the need of it, right? We're always going to need healthcare, but the percentage of healthcare that is consumed by completely preventable disease is astronomical. It would blow you away to know how much of our healthcare resource is being consumed by preventable disease, chronic preventable diseases. So essentially, we have to do a better job at that. And it's not just good, sound clinical advice. It's good, sound economic advice. Ben Franklin, a much wiser man than me, once said, an ounce of prevention is worth a pound of cure, which was his way of saying, this makes good financial sense. Even if we just disregard the clinical side of it, economics say we have to do this. And the National Academy of Medicine has highlighted this year over year. We miss so many opportunities to, with prevention. And so they estimate that every year that goes by, we miss about a savings of $55 billion in healthcare, which seems like a drop in the bucket when we're talking trillions of dollars. But we're going to need multiple drops in the bucket to solve this challenge moving forward. And so we have to start focusing more on prevention. But that brings me back to my earlier kind of gripe about how society, at least American society, just reacts to everything. We don't respond to things. We don't plan very well because nobody gets voted into office talking about the future. They talk about what's going on today. And so we are constantly in this reaction mode. And so because of that, we just simply don't invest in prevention. We don't have I'll show you, like the amount that we spend in healthcare in the United States, right? So we spend 4.4 trillion, this is 2024, almost $4.5 trillion on treatment, and yet only $1.5 billion on prevention. And when we compare that to other countries that are similar to us, right? We are way out of whack. Let me put it this way. People often think the answer to the healthcare crisis is to spend more money. It's not. Like, obviously we need to invest, but we have to do a better job of investing the resources we have, because the percent of the GDP that America spends on healthcare has gone up every single year. And you know what? The outcomes for that continue to go the other direction. So it's hard to sit in, a congressman's office and say we need more money when the money we're being spent isn't getting us where we need to go. And so a better conversation is, how do we allocate the resources we already have in a more efficient manner? And my answer to that is, how do we do more prevention? Where can we do that? And there are two ways to think about prevention. One is in the healthcare industry itself. So things like vaccinations and, child well-being checks and all sorts of different things we can do clinically to, foster prevention. But if we only put that responsibility on the clinical community, we'll never get there. And that's my call to action to you, is that reducing the demand of healthcare doesn't start with healthcare. It starts in our community. It's never going to be the clinic who is going to be able to get us to that point of preventing all of these disease and illnesses that are, consuming all of this resource at a pace that we simply just cannot keep up with. And so I like to say, like, the future of rural healthcare isn't more clinics, it's more community-based action. And I'll even take it a step further, it's more individual-based action. That there needs to be some higher degree of level of personal responsibility when it comes to things like preventable diseases. And I'm not blaming, I'll never point my finger at someone. I believe fundamentally people do the best they can with the information they have and the resources they may have. And so let's do better. Let's do better for them. And that starts how can we do that in a community? And I'm proud to live in a community that does that better than most of the communities that I get to go visit and have these conversations in. Because we live here and I think, again, we take it for granted, much like Joe and Steve's team and the reporting that they do and the information that we get, we take it for granted because it's what we have. When you leave and go see what everybody else is doing, you start to realize, wow, things are pretty good in Mankato. And I think what we do as a community when it comes to health is awesome. And it is something that we can teach the rest of Minnesota and, frankly, the rest of this country on some of the programs that we have. And so I think about our programs around food insecurity and housing. I mean, I read in the news, obviously housing is a perpetual crisis, but we're working on it. I mean, I just read an article, was it today or yesterday maybe, about, another new affordable housing being put up and stood up here in Mankato. Again, leading the way. Is it perfect? Have we solved the problem? Not by a long shot. But we're moving forward and trying to solve some of those things, because when we're talking about prevention, you might have heard things like upstream, downstream, like interventions. When we're talking about prevention, we're trying to go as far upstream as we can to solve issues at the lowest economic price point as well as the lowest health impact point before it gets to a much bigger problem. And a couple of examples where we're doing just phenomenal work in the Mankato region. I have to give super kudos to Greater Mankato United Way. They've seen the crisis, the mental health crisis that our youth has been going through. It started before COVID, but really escalated quite quickly through and post-COVID. And, they didn't just form a group to talk about the problem. Most communities do that, right? They bring a bunch of people into a room, they give them coffee and donuts, and it's an echo chamber of how bad things are. And, woe is us, what are we going to do? No, that group, they said, what are our problems? How can we, mobilize the resources we have? Who can we partner with? And they started that school mental health navigator program, which is a on-the-ground practical resource. And if you're unfamiliar with the Navigator program, essentially they raised funds and hired someone to work in the school to help families connect their kid to mental health resources. Because after all, it's hard for a 9-year-old to pick up the phone and call a mental health therapist or a counselor and say, I need some help. And many of the parents in our community, that's a complex system. I'm a mental health provider and I don't even know how to navigate the system. So imagine being that parent of a child who is struggling. And so the navigator role was created to help those parents connect the resources. So they didn't not just talk about a problem, they saw a problem, and our community responded, financially, and was able to stand that program up, which I say is a model. I go, again, all over the state and all over the country, and no one else is doing these type of things. And so that's just one example of community in action when we're talking about prevention, things in our schools, the mental wellness, our workplaces. We have tremendous employers in the Mankato region who care about their employees. And so you think about the initiatives that are happening up on campus and trying to keep our not only our faculty and our staff healthy, but our students healthy. That is a point in the direction of prevention, and we take it for granted. Lots of organizations don't do those things. And we have to, embrace and get back to those kind of, whether it be faith-based opportunities or co-op, just opportunities in our community to bring people together and work towards becoming healthier. And we have that alive very much so. Vine in the Mankato community, I can promise you, where I grew up down by Edgerton and Slayton, Minnesota, they would love to have a resource like Vine. They just don't. And we do. And so it's one of those things, again, where I can point to many places where this prevention that I'm saying has to be part of the equation and starts with us is actually happening here. And so that's kind of my call to action to you is where can you, in the work that you do, in the service that you provide, or just the communities that you're connected with, start to have that conversation about, look, we need to do better at keeping ourselves healthy. Not just because it's the right thing to do, but because the alternative is not sustainable. The entire system will collapse if nothing changes. And that was the mission of the Center for Rural Behavioral Health, is the mission of the Center for Rural Behavioral Health, which is our part of it is to create more providers, but at the same time, asking the community to do a better job of preventing the challenges from needing, because it's going to take both of us working on those things together. So that is a lot of information, high-level information, but the goal of my opportunity to speak with you, because Joe said, hey, make it about 35, 40 minutes so we can have what I'm hoping is a more robust conversation in this room about these challenges. But my goal with this information was to show you, yes, it's bad, and it projects to get worse, believe it or not. Most people can't believe that, actually, when I tell them that. But it's not that we should just stop and put our hands up and say nothing is going to happen. We should also not just stop and say, oh, the government is going to fix this. That isn't going to happen either. We, and I mean collectively, communities, families, individuals, have to take that initiative to lower that demand so then everybody can thrive. And so with that, Joe, I'll turn it back over to you.
Yeah, thank you, Thad. Is that on? Can you hear me? Okay. It is on? It says it's on. Okay, we just want you to, there you go. If you have a question, we want you to use the microphone because then it will show up in the recording. So, are there any questions?
I have a lot, but I'll restrain myself.
No worries.
A couple things popped out through your whole talk.
You got to use the mic,
And
though.
one is the workforce. And recently in Mankato, you had a 5-hour conference on workforce development. So that's one of the things that is going to help. And it has to do with immigrants. And you know, I think a lot of people in what I call greater Minnesota, then I'll call it rural, but I always say this is greater Minnesota. The rest of the metro area doesn't understand our importance. They don't realize that we have quite a bit of respect and honor some of our immigrants. They think, you know, you're kind of closed-minded. That's baloney. If you talk to people, that's not really what they've got down deep in their hearts. I am actually involved in a long-term care facility in New Ulm, Minnesota, and with the legislature, which is a huge disappointment, and that's an education part that's up at the Capitol. And we can do that, but when they don't listen, you can find your answers some other place. And we have a number of different countries that are represented, different languages, and they're very welcomed, and the residents are too. In any group, you're going to have some that will say, I don't want anybody who's not looking like me to take care of me. Well, they're in the minority, and you have to keep telling them that's in the minority. That's in any human population in the whole globe, that sometimes, you know, you kind of scapegoat and said, you don't look like me, you don't talk like me. And that's learned, unfortunately, very early in those kids' lives. So that's one thing. The other thing is AI. I'm not as pessimistic, because there's a study that's come out, and then I'm going to give this to somebody else because I could talk more than is my fair share. AI in the radiology department for the last 10 years or so is being researched over in Rochester. And they're using some things now where AI is going to help those radiologists who are super specialized. One example, if you have kidneys, all of a sudden you have your kidneys imaged, and you see this little, what we call fascinoma, or this little bump or a cyst. We don't know if that's something that's going to turn into something bad, and if it does, we don't know what the time frame is. So now we don't know how often they should come back, you know, and be frequent flyers. AI can actually make measurements that would take the clinician hours. Once they can follow from 1 year to the next, and all those calculations are done, now the radiologist can take their clinical information and apply it to that. So that's one place where it's really good. And the other thing is you're involved with behavioral health. Virtual visits are going to be really good, but it's going to take a lot of sensitivity to do it right.
Yeah.
And you know, the other one is suicide rates, and that's the I think I've got it right, QPR, which is if you have someone who is feeling uncomfortable about their self-preservation or they have thoughts of self-harm, then you should have the courage and be sensitive to question the person. And then when you get to a point, you persuade them that there is help. You don't have to end up doing some things like self-harm that could kill yourself. And then you should be knowledgeable where to send those people.
Yeah.
So that's all I'm saying.
No, thank you so much for that feedback. If I could just respond, you know, I'm glad you brought up, you know, telehealth. You noticed in here, I was pretty much exclusively focused on workforce because, as I mentioned at the beginning, we could spend a whole semester talking about this topic. And if you're interested, just come audit my class. Not next year, I'm on sabbatical, but after that, come in and we can spend a whole semester talking about these things. But specific to like telehealth, which I would lump more in like the clinical delivery side of the conversation, more so than the workforce. There is some overlap, as I'll get to here. What we've done with telehealth has been revolutionary for all sorts of medicine, not just behavioral health, but where that specifically has opened up access to care for lots of different people who otherwise wouldn't have it. Oftentimes, I find myself, particularly those who are making decisions around policy and where we're making investments, slowing them down. For example, I've had legislatures say, what do you mean we have to invest more in rural mental health? We have telehealth now. So as long as they have the internet, they have this problem solved. And I find myself saying two things. First, I say, do you think there's like a warehouse of therapists in Edina that don't have anything to do and that they're just going to hop on a Zoom call with a farmer in Nicollet and that's going to be there? No, the Metro faces some of these same challenges. They just don't face them maybe in the depth in which we do out here. So there's not just this unlimited resource up in the cities for these telehealth visits either. So that's where it kind of centers back to a workforce issue. The other thing within specific to behavioral health, because you mentioned it, where telehealth falls short is so much about mental health care is the relationship, more so than anywhere else in medicine, right? Like whether my dentist understands the way I grew up and what I go through doesn't matter to me. As long as they put that drill where it needs to, we're good to go, right? But my therapist has to be able to establish a connection with me, and part of that is understanding one's culture and, dare I say, even way of life, which is a slogan that's been hijacked to some degree. But my point is, even if we connect that dairy farmer outside of Nicollet to a therapist in Edina, it often doesn't work out because that therapist has maybe never left the metro area and is trying to understand the challenges of dairy farming in rural Minnesota, and there is a disconnect there. So while telehealth in mental health has been phenomenal, and in other places of healthcare, it isn't the entire answer. And that's where I often push back on people like, well, no, just getting them broadband won't solve the access issues to healthcare. And that is true of even physical healthcare as well, that there is some limitations to that delivery model. With that delivery model where rural health is doing some incredible things, they're like mobile clinics. We see that with the, Open Door Health Center with their mobile dental lab and dental clinic. Like those are the innovative things that we have to continue to do, because hospitals and specialties are not going to survive in rural Minnesota. They're not going to survive in rural America. And there's one of two choices. We can complain about it, or what we can do is say, okay, if that's not going to work, what can? And how do we then mobilize and move in that direction? So I appreciate those comments across the board, what you had to say. Thank you.
I appreciated the comment about QPR, right? Question, persuade, refer. Is that right? Do I have that right? So I just learned that in the last year because we did a story about kids at the high school who have groups. Another thing you can point to, I think, that shows we're trying some of these things, we're trying to be successful. I thought your comments about Mankato community are particularly important, about the things we're trying to do. Mm-hmm. That's always the key. And the newspaper wants to be part of that, as always. So let people know, to inform, have a mass communication about it. Other questions? In the back here.
I am a member of what my healthcare professionals now are calling that age group. And I have seen a number of my contemporaries who wish to live in a warmer climate and yet want the health care that Minnesota provides. They not only want a warmer climate, they want a state where they don't pay income tax. And I'm hoping that you can make some comments regarding the economy of that age group.
Yeah, so I think that's part of that migration conversation. And, if I'm understanding you correctly, that there is a group of people who want the benefits of Minnesota. We have good health care. We have exceptional health care, I'll go as far as saying, especially when we start to compare to maybe some of the states that people want to go to that's warmer to be at, right? States where they might not have a state income tax. I think that it will have to work itself out. I think what we're seeing with this migration to some of those states is they are, and this is just my opinion at this point, I'm not the expert in that piece of it, but they are embracing the benefits of no income tax and the warm weather, and at some point they'll be faced with the reality that it's missing these other really important things. And so I think there'll be this pendulum of let's move, and I'll just call it Florida, let's move to Texas, and at some point when the dust settles and they're missing those things, or there isn't as many opportunities as maybe they were accustomed to here in Minnesota, maybe those cold Februaries won't be so bad anymore. But if I'm understanding the question correctly, I don't know if you're looking for more of an economic response to it. The thing with the dependency ratio, I guess the dependency ratio will improve if older adults, non-working adults, leave. So in some respects, the dependency ratio won't tell that whole story. But I don't know. I don't know the answer to that from an economic standpoint. What might happen? What might happen here in Minnesota as those individuals may leave, and ultimately the burden on those states? I'm guessing it will be significant, that they are going to have a migration of people who are consuming more of a resource than they are providing, and they're not benefiting economically from a tax base standpoint. I think at some point those states will look to the rest of the country and say, we need your help. Or they may have to, in those states, change their policy to keep up with what's happening. So not my area of expertise, but I think that would be my response to that.
I think your comment about the dependency ratio was really fascinating. I've never heard that before. So people that go to another state, their dependency ratio is going to get worse.
Yeah.
Right?
Yeah, absolutely. No, it's so interesting, and we try not to use dependency ratio in a snapshot, but rather like the trends of it, because you can kind of see what's coming. And Minnesota, as I mentioned, has a pretty good one, but if you start to like localize that, you can actually drill in with Minnesota's got great data. We got a great demography, state office, and you can drill into like by county what dependency ratio is. I'm writing a paper right now with the Center for Rural Policy and Development on the Iron Range, and so we're doing an in-depth kind of analysis of the Iron Range, and I'm joining them as a researcher to dig into that. And I'm looking at things like dependency ratio, and there are pockets of the Iron Range that have a dependency ratio approaching 90%. And so like that is if you look across the country, any community, any metropolitan area, anywhere that's had that type of tip over has never made it. It is the end of that community, because it'll just start to slowly like fall into that sinkhole. So yeah, we have pockets in Minnesota that are really bad, and they're often in more rural areas. Rural is an older population, so the dependency ratios are more challenging, which puts a larger strain on our health system, which is all part of that piece.
Other questions? You had-
If we want people to be healthier, could you go over, say, 5 activities that should be worked on and how they should be accomplished?
Yeah. I mean, I think for me, I'll try to give you 5, but I'll give you the big ones that I know, right? Number 1, stop smoking cigarettes. That is the single greatest preventable thing we can do. Is we just know how bad things like cigarettes are. So by simply not smoking, which we've done a pretty good job in this country, right? We've done a pretty good job at reducing the number of people who are consuming tobacco-based products. They have traded those in for vape pens, obviously, but there's consequences to those. But smoking, things like drinking, we live in a culture that romanticizes and celebrates drinking in a way that no one else in the world does, right? I mean, alcohol is everywhere, but the way we view it and the way we socialize around alcohol, we often gloss over the fact that, last year, about 95,000 people died as a direct result of, chronic illnesses related to alcoholism. And so that isn't very romantic when we tell people that nearly 100,000 people died because of their Bud Light, and they like to laugh at the commercial that shows during the Super Bowl. So things like substance use are one of those preventable things. And then the obvious, exercise, getting out and walking. That's, again, an area where Mankato beat so many of our other rural communities. We have prioritized things like bike trails and outdoor activities, and those things matter in the prevention, the long-term prevention. And then one is food security. It is, I don't know the word I want to think of. I'll use unconscionable, like that the worst foods for us are the cheapest, right? That that again, not my area of expertise. I'm not a nutritionist, but the things that we often, when we're limited on our resources, are able to buy are the things that make us sick. And so it is like, how do we prioritize healthy food? How do we, even before we do that, we have to inform people about that. So many people don't even understand what they put in their body and its impact on things like preventable disease and illness. So diet, exercise, substance use, I got to 3. Smoking, yeah, that substance use, that smoking piece is a big one. Oh, absolutely. The importance of being connected. Another great thing. I mean, like just tonight, how many events are going on in Mankato where community members are coming together? And like, I think we've overlooked the importance of connectedness, particularly coming out of COVID, and we've been more isolated. And even though that in and of itself isn't a health consequence, that chronic isolation weighs down on your mental well-being, which then permeates throughout your body. So I appreciate that comment. Being more connected is a part of that prevention plan as well. So I gave you 4. How about that?
Let me go over here.
I'll just make one comment. The research that the Blue Zone people have done for the Centurions really is very sound in terms of what we could do, and it is connection.
Yeah. Yeah, absolutely.
is actually towards the top. I have a question about education. Are we, you, changing how you educate mental health practitioners to work via Zoom or that? Because to me, it's very possible to have the same kind of relational things, but you have to train differently and think differently.
Yeah. No, absolutely. Great question. There has been research that has been examining the effects of whether somebody experiences a mental health treatment via in person or online. And what we're learning from that is informing how we train people who want to primarily work online or have any exposure to online treatment. And so we've even gone as far now where there are national certifications and credentials that one can get where they've demonstrated a competency in telehealth. So they might take a 40-hour class that teaches them the nuances of telehealth and different things to have to look at. But it's a part of that teaching. So the education system is responding to what's happening in the workforce. Our challenge is we have a lot to teach them in just a couple of years. And so it is a constant battle to how can we get them to a place where they can help people, but it's on them to continue that education and learn what they need to be better clinicians.
So I was a therapist for 25 years, but I've been an executive coach the last 22.
Sure.
And I believe you could do it simultaneously in your education in terms of how to form relationships, because I wasn't real keen on the idea, but I have found it amazing
Yeah.
with not really a lot of extra training.
Yeah.
The other piece is talking about AI and matching therapists. So you have somebody in Edina that doesn't know anything about farming. I can't believe that you can't put enough information in a database about therapists and need. Because I worked in a clinic that had triage, and they knew our individual personalities and quirks.
Sure.
So when somebody came in, they were matched.
Yeah. I think that was, in best case scenario, you would have more of that. The problem is you might have been on a waiting list for 6 weeks and you're going to take the first person that's available, whether they are a good match or not, right? I think about if one of my kids needed care, obviously I'd be like, okay, who might be a good match or who might have an expertise? But if things are bad enough and they call and say, we have an opening, I would probably send them, right? So I think you're exactly right. Where we could do a better job and where AI might be able to help do some of that matching, I think that's kind of icing on a cake, really, as far as like, how do we just get the bulk of that workforce in place first? But I couldn't agree more with the importance of doing that matching, as well as your comments on telehealth. I've had clients and patients say, this is how they're going to access care forever. On the same hand, I've had people say, I'm never doing that again, that it was a poor experience. And so I think having both options available is always what's best.
Yeah, but I think it goes back to how the practitioner developed the relationship.
Yeah, absolutely. That's a big part of that.
Thad, a question I had on this is, for years we've heard that there are better outcomes in socialized medicine countries and in terms of spending, that they have better outcomes and we spend more money than all of them, but we don't have as good outcomes. And then secondly, is this whole problem that you're describing, we're going to run out of workers to take care of us older people, a worldwide issue?
Great. To your second point about what is it, yes, I do think there are lots of countries that are struggling with some of these same challenges, right? I don't know enough to say if it's at the same degree that we are, but this workforce crisis, this not having enough educated people to do these professions, I think is felt across the globe. So what the specifics are, I'd have to probably take some time to look into that a little more. And then your comment about outcomes and socialized medicine or single payer systems, that's a whole other presentation, I think, that again, not me would give, because that is not, I guess what I'm saying is that is such a explosive topic that I feel if I were to provide commentary on it, it would simply be my opinion, and I don't know if that's what you're looking for. You know what I mean? Like,
That's really what I'm looking
yeah, yeah. Well, I try when I get up here and put my suit coat on, I try to leave most of my opinions at the door. It's hard to balance like being an educator and what your opinion is on things. I think for me, the role of government and healthcare, I mean, it is, I don't know. You hear, I think, what you want to hear in that conversation most of the time. So if you tend to lean more of this is a good idea, you tend to reinforce that idea with the stories that support that. And if you tend to lean against things like single payer system, then you find those stories. My opinion on the matter is if the United States were to move in that direction, we would have to start over. Like our healthcare system would need to be completely dismantled. This idea that we're going to start here and then drop that on top of it would not work. So it would take a lift that I just don't know if there's an appetite for. And at some point we might not have a choice and we will have that appetite, but it would start with completely dismantling the way we think about medicine and how it's delivered, and then building it up with that idea of a single payer system. That's, I guess, my response is, you couldn't have one without the other. The answer isn't let's just socialize medicine and make it a single payer system and not change the system. That won't work. That's, again, my opinion, because I'm not the expert on that.
The reason I asked the question about is the world experiencing this, because I think I just read recently in the Free Press that Japan has a real problem.
Sure.
They're 1.54 children per married couple or something like that. And it's going down.
Yeah.
You know, it's still going down, so they have a real issue there.
I think there will be again, not my area of expertise, but a rebalancing. There's going to be a philosophical rebalancing of what we think about immigration and where people come from and how we meet the needs of our community and our country. So yeah, Japan, us, lots of places I think are struggling with that. It's truly like existential crisis, right? There's a very practical crisis in that, but it's also one I think of, an existential, philosophical one as well.
Well, carrying on from that, you've got the two sides. You got America is we're kind of spoiled, but I mean, basically, a lot of these things, when we've become a country of everybody has everything, almost. I mean, it's too easy in some ways. Survivorship is gone. There's people on the very low ends that are still surviving and having a tough time, but you've got and we always are used to getting our way, so to speak. And so now we have this issue of people, when you talk about smoking, when you talk about doing things, well, if I want to smoke, I want to smoke. It's a free country, right?
Yeah.
I want to smoke, I want to drink, I want to do this, I want to do that. So America just gets bigger and bigger and more unhealthy and more unhealthy, because that's what happens when you are successful.
Yeah.
You unfortunately, you've got a question now of, we've run into that where people, I want to continue doing these things, but I don't want to not do these things. So, insurance companies do a little bit of this and say, if you're going to smoking, you're going to pay a little bit higher. I don't think they've done enough of that. I don't think people get penalized enough for causing the health things that they could have prevented.
Yeah.
And so there's an economic part of it.
Yeah.
There's the economic part of it and the stubbornness of the average American, and we're all guilty because we love to have things the way we've had them, being successful, having things,
Yeah.
And unfortunately, there's the downside of it. And so you got these people. So who is, when right now, of course, we're in economic, or I should say, political times when there's a lot of no to this, no to that, and we all know who I'm talking about. And people don't like it. They don't like to be told no here. But there aren't very many legislators that have the guts to say, you can't do that.
Sure.
You can't do that. You can't do that because it's not good for you. It's not good for us. They don't like hearing that.
Yeah.
And they don't want to hear that because I won't get reelected if I say no. So who is going to be the one with the guts to say, people, no, you're going to get penalized.
Yeah.
You smoke, you're going to get penalized. You do this, you're going to get penalized. That has got to come to an end, and people have got to get fit.
Yeah.
We are so fat in this country. It's amazing. And it's easy to do because we've got, just like you said, so many things. We eat poorly and we do all these things because immediate gratification. I mean, we want the good life, and yet it takes so much discipline to say no.
Yeah.
And a lot of us don't have it. But who's going to have the guts to say, you're going to have to pay for that?
Were you at dinner with me last night? Because I promise we were having this conversation. I was at dinner with some of the National Rural Health Association folks and some hospital CEOs. It is like truly the conversation we were having, and they were comparing it to like automobile insurance, where if I drive and get speeding ticket after speeding ticket, what happens to my insurance? It goes up because they say that behavior causes accidents, that's economically disadvantaged. But he says in healthcare, there is no penalty to making, again, poor choices. I'm not talking about, pre-existing conditions that people were born with and to no fault of their own, but to your point about smoking or things like diabetes that is caused by, the lack of exercise and eating right. So that we had that philosophical conversation and how that would need to change when we're talking about the role of insurance in that. But to your question about who is going to do that, that's the wrong question, right? Because that is part of the problem is we're looking at somebody else needing to do that for us. It needs to be internally. It needs to be collectively. We have to take accountability for that. And I think that has just been a shift of American culture of, where that responsibility lies. And that's a philosophical conversation that we would have to have on a different day, but it is an important question of like, from an economic standpoint, the trajectory we're on isn't sustainable. How can we get better information to the people who maybe are making poor choices, health-related choices? Because in many instances, I believe people do the best they can. And so let's just get them better information so they can make better choices. So that's part of it as well.
I think so much of this comes down to education.
Mm-hmm.
Education at whatever level that is about, and I think, we always want the schools to do everything that the parents don't do, but, integrating more of, and they're probably doing this, I don't know at what level all the time, but it probably varies from school to school, state to state, whatever, about healthy eating and healthy this, and really instituting that into our minds.
Yeah.
And making it, and I know they're doing it to some extent, but again, you get into the lower economic, areas where people, some like down south and some of it seems like their healthcare is so much worse than ours is, and it seems like education is worse.
Yep, they're correlated for sure. Yeah, absolutely.
And so I think that's where education again is so important for so many things. You get a little bit too much education, then we get kind of weird. But if we get
You must hang out on campus.
ivory tower.
Is there, I think we have time for one more question possibly. Anybody got one more question?
I just want to give you one example. When you're talking about education, the CDC, the Center for Disease Control, was very disappointed after COVID-19 that we have more and more problems convincing people vaccines are saving lives. So they had a bunch of educators all over the country say, why is our message not right? You know what they came up with? They said, don't go and pound on people and say, science says this and why don't you believe it? What you do is you respond to the person when you make a recommendation and they kind of resist. Then you say, well, there's this information and stop right there. And then you say to the person, okay, you always have the right to change your mind. And that's a whole different way because now if they change their mind, it's not like you say, I told you so. It's like you don't shame them. They've come, they've marinated all those ideas in their head, and now it's their choice, and it's a better choice. So it's a different way.
Yeah. Yeah, no, you hit a nail on the head. Again, another facet of this. If Joe would have given me 3 hours, we could have had the whole conversation, where healthcare historically has been personal, and now it's as much personal as it is political. And that has been a shift for the worse, because now we start to question things that we have. And I think questioning things is healthy. I'm not saying like everybody knows everything, but my point is, we have politicized medicine in a way that I think is contributing to some of these challenges, particularly as it pertains to things like prevention, which is going to be required for us to survive through this. So we have to get back to this place of making it a more personal thing and less maybe more political. So
I hope in your position that you can go and try and get people in your field of behavioral health, like they have community health workers, which they do at Open Door, which the Free Press has advertised and works. So if someone who's in the community maybe doesn't speak our language or has a different cultural background, they can pick up on who's having some mental difficulty, and they can help get them to you people. That's really important.
yeah. No,
I hope you get that model.
the emerging professions in healthcare, we had this conversation at the conference where just in the past 25 years, the number of new professions that are helping us meet some of these challenges. I think about mid-level practitioners. I mean, many rural communities wouldn't have a prescriber without a physician assistant or a nurse practitioner. And those things aren't, we take them for granted like they've been here forever, but they're pretty brand new in a lot of respects. And so how can we innovate and evolve to meet those needs and meet those challenges? It has to be part of that solution as well. So great comment, and thanks, Joe.
Thanks, everyone, for coming. It's been a great conversation, and I'm sure everybody got a lot out of it. I want to thank our sponsor one more time, Minnesota Valley Federal Credit Union, for bringing this to you. Thanks for coming, and let's thank Dad.
Thank you. And if you would like this PowerPoint, I'm happy to share it. Just send me a quickie. I don't print anything anymore. I stopped printing probably about 8 years ago. So, but I'm happy to share it. There's nothing proprietary in here. And so if there's anything of interest to you, or if you'd like the longer version that I sometimes do, just let me know. I'll send you what I have. So
When's your next talk?
my next talk. Yeah, it's such an interesting topic with, I mean, yeah, we could literally spend 3 hours and we would not have had enough time to really get to all of it.
You had TED Talk.
I did. Yep.